So today what I'm going to be talking about is prostate cancer and bladder control. It's more than just a Kegel. And I'm hoping to go over today, prostate cancer and the treatment interferes with bladder function and bladder control. And I really believe that before one can understand, well, things are different, it's really helpful to understand how things are supposed to be. So I like to start off with just explaining, well, this is a bladder and this is how it's supposed to work. And then what happens if you have radiation? What happens if you have prostate surgery? We're going to talk about pelvic floor exercises, i.e. Kegels. I am not including pelvic floor exercises or information around incontinence with sexual activity and or erectile dysfunction. And there's a whole area on that as well, just not enough time to do all of that. I also do want to share information about the Prostate Cancer Supportive Care Program. All of the information that I'm talking about today, as well as the sexual incontinence and erectile dysfunction related to the pelvic floor component, is in the Prostate Cancer Supportive Care Program, or the PCFC education session, and we do all of this with treatment. So I just want to take 1 second, if that's okay with people, to share a little bit about the Prostate Cancer Supportive Care Program. It's government funded. There's no charge at all for any of the services. It is an amazing program in terms of the caliber of the people, the treatment that's given, the options that are available, the research that's coming out of it. So basically, it's supportive care. It's not directed at cancer treatment, but all of the fallout from having that diagnosis and treatment. There's different modules, and people pick which module works for them. These are the different modules. There's the contact information. You can just phone or go on the website and get the email address, and you can choose which module is helpful or appropriate or of interest to you or your support to your loved ones. And so it's just, anyways, it's amazing. I think it's quite a unique program as well. So that's the information about PCFC. Full disclosure, I work in that program. I'm the physiotherapist. I'm actually, another thing that's important, I'm the provincial clinical lead, but the program has gone provincial. And there are sites in Kelowna, Victoria, Prince George, Vancouver. Did I say Victoria? Yeah, and one of the silver linings to COVID is that now these services are available through virtual health or telehealth throughout the province and the Yukon. Free treatment, all of these areas, doesn't matter where you live. So I just want people to know about this program and the resource. It's fantastic, and anyone in BC or the Yukon can access these services from anywhere. Okay. Oh, there's one other slide. It's just the content, but I've already talked about that generally. It's the same content that I'm talking about today, as well as the incontinence with sexual activity and erectile dysfunction. So, excuse me, moving into the content for today, I'd like to start talking about, well, how does the bladder work? So really, I don't know if people are aware that your bladder is just a muscle. It's a hollow muscle. Now, we have two types of muscles in the body. We have automatic muscles and intentional voluntary muscles. My heart, my intestine, my bladder, those are automatic muscles. They have their own rhythm of contracting and relaxing. I can't say, oh, heart, please speed up. Oh, no, slow down a little bit, speed up. It doesn't work that way. I can't say, oh, biceps, tighten, relax. I can do that for voluntary intentional muscles. I can't do it for my heart or my intestine. I'm constipated, please speed up. Or if I have diarrhea, oh, no, please slow down. The muscle has a different control. It's more of an automatic control. The bladder is one of those automatic muscles. So the bladder is a hollow muscle. It's a container, as the kidneys are cleaning our blood. They're manufacturing a waste product, that's urine. The urine's going into that bladder. As the bladder fills, it starts to stretch. When it gets to a certain point, doesn't like that stretch, there's little sensors in it, it picks up that stretch and it says, hey brain, I need to pee. And then remember, this is what's supposed to happen. And then the brain says, oh, bladder, I just took you half an hour, 45 minutes ago. You're not really full. You just be quiet. Muscles tighten up, the closure muscles. You go on about your business. You forget you have to pee. That signaling might happen 1, 2, 3 times or whatever. After a while, it's quite full and it signals, it says, hey, brain, I'd like to pee. And this time the brain says, yeah, bladder, I'll take you. But I can't just this second because I'm in the middle of a presentation. Or, well, I'm on a walk and there's no tree and no toilet. You're just going to have to wait. Or somebody's in the toilet. You just have to wait until it empties, okay, until the bathroom's free. So you finish your talk, your walk, the bathroom's available. You get up, you calmly, slowly walk to the bathroom. You open the door, close the door, you walk in. You look around, you look, oh, this is a beautiful art in this bathroom. You look out the window, oh, lovely weather outside. You get to the toilet or the urinal, get your clothes ready. And then when everything's ready, then your brain puts this automatic process in place. It relaxes muscles that are closing the bladder. Those relax. And then the bladder muscle itself contracts. And when it contracts, it moves the urine out of the bladder. And as soon as the urine is out of the bladder, bladder relaxes, muscles tighten up, and you're back into storage. Okay, that's what's supposed to happen. And in the meanwhile, while your bladder had urine in it, you're going from sitting to standing, you're coughing, you're walking, you're sneezing, you're jumping, whatever. There's nothing leaking out. It's a secure container. Okay, then you have treatment. And so I'm going to be talking about radiation first, a couple slides on this, then we're going to be talking about prostatectomy. And remember, if you have any questions, send them over to Len. So urinary urgency is, remember I said that bladder fills and it gives a little stretch and a little spasm, and it says, hey, brain, I need to pee. And the brain says, calm down, I'm not going to take you right now, and you forget about it. When you have urgency, instead of having a little contraction happen, that bladder is having a temper tantrum and it's saying, take me now. And sometimes the parent to that temper tantrum says, yeah, sure, and just drops everything and runs. So what happens when we have radiation, someone has radiation, whether it's external beam or brachytherapy, the radiation itself irritates the lining of the bladder and the urethra. It can also irritate the rectum and the colon, and you can have frequency and urgency from bowel as well. And so as that bladder stretches, it can't tolerate the stretch because everything's irritated, so it has a temper tantrum. And so the person is going more frequently with a sensation of urgency, and there can also be burning when the person is urinating or voiding or going pee. There can be associated incontinence, and this usually lasts for about 4 to 8 weeks after treatment. The treatment of the intervention itself for urgency and frequency, it doesn't matter why the person has it, whether they just have it independent of treatment when in their 20s, 30s, or because of radiation, the treatment is the same. So what each person chooses, again, is very individual. So there are medications that the person can take, and they actually help the bladder to not be so reactive to stretch. There are side effects with those. There are some dietary, and some people find it helpful, some not. Same with all of this. What works for one person might not work for the other. The next slide has a list of dietary irritants, and I wouldn't say just eliminate all of those. We recommend people eliminate for a couple weeks and then gradually add back one item per week in the quality and quantity you would normally have to see what items irritate you. The common ones are caffeine, coffee, tea, chocolate, cola, carbonation, alcohol. Those are the common ones. But I've had people say, you know what? It's not even citrus. It's just grapefruit. I can't have grapefruit. So we really recommend people do an individual assessment of what their irritants are. The other thing we ask people to do is to increase their fluids. And often when I ask somebody to increase their fluid, they look at me and say, did you not hear what I'm saying? I'm going really frequently. I want to go less frequently, and it's really urgent. If I have more fluid, I'm going to have more frequency, and it's going to be more urgent. And we really encourage people to try increasing their fluids, because sometimes, and quite often actually, having a dilute urine actually helps calm the whole situation down. So that can be one helpful thing, non-irritating fluid increase. The other thing we teach is urge management. Remember I had said the bladder is having a tantrum and the parent goes, yeah, sure, drop everything, run to the toilet. So what we actually find is that, remember when I explained how the bladder works, there's the bladder, the brain, the bladder, and the pelvic floor. And so it can be really helpful to keep that brain or the parent calm, to use some very specific cognitive behavioral urge management techniques, as well as tightening the pelvic floor. And so those are some specific techniques that we would get into in treatment. Incontinence usually resolves within 4 to 8 weeks after treatment. And I just need to change this again. Yeah. So those are the dietary components. If at any time, whether you've had prostatectomy or radiation, if you're not able to pee or having difficulty voiding, you want to see your doctor. Anytime you have any kind of injury in your body, whether it's on your hand or inside your body or on the surface of your body, it heals with scar tissue. And it doesn't heal with the tissue that's native or natural to that area. So when you have radiation, there's going to be some scar tissue. When you have a prostatectomy, there's going to be some scar tissue. Now, scar tissue can actually form in a way that starts to occlude or obstruct the urethra. And that's when people have a stricture. That's what they're talking about. So it's really just scar tissue in not an ideal place. So if you're having difficulty initiating your stream is definitely slower, or you're having to push during the stream to get the urine out, you want to go see your doctor just to be evaluated to make sure there's not a stricture there. Sometimes a little bit of stricture can be helpful because it can help some people with incontinence, but we do not want people having strictures that are making it difficult to empty the bladder, because that can run into very serious other complications. So that's something you need to be discussing with your physician. And the physician will know how to rule out or rule in stricture or not. Many people, quite a few people, 2 to 5 years after having radiation, then the incontinence that develops then. Radiation, you have it, and that's how radiation works. It lives in the tissue for a while. And so over time, it can change the tissue, muscle, and some nerve. And some people develop incontinence 2 to 5 years after radiation. If that's happening, I recommend 2 things. Check with your doctor to make sure it's nothing else, and see a pelvic floor physiotherapist who's able to help with management. Okay, I'm moving now into prostatectomy and stress urinary incontinence. So I'm just curious, I'm not going to do a poll at this point, but I know that most people that are having incontinence after their prostatectomy, it's not associated with the urgency or frequency that's related to radiation. But what happens is with movement or activity or certain positions, urine's coming out. So often guys will say, well, when I stand up, going from sit to stand, when I cough, when I sneeze, when I laugh, when I bend, push, pull, squat, walk, run, jump. And it might happen all the time with each of those, or all the time with some of those, but often it happens only sometimes with those activities. So some people might leak when they cough, but only sometimes. And it's a whole bunch of factors in that moment that will cause a leak or not, depending if they're present. So why is that happening? Your bladder's just sitting there, relaxed. It's in its storage phase, and urine is coming out. So when a person coughs or exerts themselves, anytime you use your abdominal muscles, your head, your arms, or your legs, you generate pressure inside your abdominal or pelvic cavity. So you get this pressure inside. Pressure goes to the path of least resistance. So it's not going to, when you fill up, when you cough or you sneeze, the pressure is not going to go out your bones. That's a very firm area. It's not going to go up heart and lung. That's a very dense tissue. It goes down to the bladder, which is the softest point, and it squeezes the bladder, and urine comes out. So remember, I talked about your bladder being an automatic muscle, and it has this bladder, where is it? The muscle here is relaxed when it's storing. The detail I didn't get into before when I was talking about how the bladder works is, while the bladder muscle here is relaxed, this part of the bladder at the bottom of the bladder, right where the opening and the urethra is, the exit out, this part is automatically relaxed, while this part is automatically contracted. So it closes that. So before your surgery, when you coughed or sneezed and you generated that pressure, nothing comes out because you've got good automatic pressure. But when they remove the prostate, you can see right here how the prostate lives just into the base of the bladder there, where the automatic closure is. So there's not a space between. It's not only just touching, it's actually right into that bladder wall, okay? So when they remove the prostate, they want to get every single prostate cell out. When they do that, they interfere with the automatic closure. Some of this gets taken out as well. So your automatic closure system is interfered with. So now when the person coughs or sneezes, if the pressure squeezing that bladder is greater than the closure pressure, they leak. So that's why it's called stress urinary incontinence. It might be emotionally stressful, but the stress is referring to the physical stress overcoming closure pressure. So that's a difficulty with the automatic system. But our bodies have an intentional voluntary system in our muscle function. So remember, you've got the automatic muscles and the intentional voluntary muscles. So we have the pelvic floor. Our pelvic floor is an intentional voluntary muscle that we can use to stop urine leakage. So I don't have my model of the pelvis with me, so I'm going to try to describe. So we've got a pelvis. If you put your hands or you feel right above where your penis would be, there's a hard bony area. That's your pubic bone. Here are your sort of this hip bone, a shelf. And so down low and around this area and at the very back, you have your sacrum just above your tailbone. That's the bony pelvis. It's like a bowl. The floor of that pelvis, or the bottom of the bowl, is actually a muscle. And that's the pelvic floor muscle. So if you look at the pelvic floor, the pelvic floor has two layers. There's an inside layer, the levator ani, and then the superficial muscles, or the urogenital diaphragm, the more outside layer. When someone contracts their pelvic floor, this whole unit works together. You can't separate it out. So the pelvic floor actually has several different roles. People have heard about core stability or lumbar pelvic stability. It's one of those muscles that has a role in sexual function. Today, we're going to be talking about it in terms of its role in managing bladder control. Similar roles for bowel control, and the contraction is the same, whether you're having bowel, bladder frequency, urgency, or incontinence. So I'm going to be having everybody do a pelvic floor contraction. So, and after this, I'm going to be asking people some questions, and then we're going to do a poll, and you can type a Y or a yes or a no answer to Len, and then Len will report back the numbers. So I want everybody to get in a comfortable position. I'm going to ask you, not yet, when I show you the next slide, I'm going to ask you to contract. I'm going to have you hold that contraction for about 10 seconds, and then I'm going to ask you to relax the contraction. And then I'm going to ask you those questions. I'm not sure where people are in their prostate cancer journey experience right now. If you do have a catheter in situ in your urethra, draining your bladder at the moment while we're talking, or if you're viewing this at a future time, please do not do pelvic floor contractions until that catheter is out. There are differing opinions amongst urologists, and many urologists recommend that you do not do pelvic floor contractions while you have a catheter in situ if you're post-op. So you'll understand the team analogy in a minute. So I want everyone to sit there, relax, think about your pelvic floor, and now contract it and keep it contracted. Hold it, make sure you feel it. Feel it, keep the contraction there. I want you to feel it, keep it there. Make sure you can feel it. Okay, let it relax. Great. Okay, how many people, and this is where we're going to do a poll. Okay. How many people, yeah? So how many people, when I said relax, felt their breathing let go? Yes or no to Len? I'll give you 10 seconds and then Len will report back. So how many people felt their breathing relax?
Marcy, I'm having difficulty with that. screen for the
Oh,
list. I can't see the list.
okay. All right. Send it to me. I put it up. So everybody on your chat, if you can just send it to the group. Yeah, just send it to the group. Let's see if somebody just send let somebody send to the group. Yes or no? Yeah, great. So how many people felt their breathing relax? How many people? Okay, great. Okay.
That's
all
good.
right. Next question. Leave that one now. Next question. How many people felt their gluteal or their buttock muscles relax?
No.
How many people, next question now, how many people felt their abdominals relax? Like the upper abdominals, like a good abdominal let go.
Oh.
And how many people felt their inner thighs relax? Okay, so we've got a feel of it. What I want you to know is that none of those are your pelvic floor. So they shouldn't have been contracting. So we know that correct technique based on verbal and written instruction is often insufficient. Most of the research is from women, but the research, the little bit that's out there for men. And what we see clinically is that people have read it or seen a video or had verbal instruction, and they're coming in and they're not doing it in a way that's effective. And sometimes they're doing it in a way that actually pushes their abdominals, their bladder down. And there's just another study published that when you breathe in, your bladder pushes down. Abdominal over using abdominals push the bladder down. So correct technique is really, really important. What's really exciting, just a little aside here, I think I can talk about this. What we're doing at the Prostate Cancer Supportive Care Program is we're noticing even better outcomes. We think we need to look at the data that is, we're thinking that people are actually doing better from telehealth. It's not verbal and written instruction because I can see the person. So I can see their incorrect usage pointed out to the person. So some of the ways and some of the things we're doing with treatment, it's looking really interesting. But if telehealth is not the same as watching a video or just telephone health. So what the research shows right now is that verbal and written instruction is often insufficient, and that's what people's experience has been here in this discussion. So why is there this confusion? So you notice there was a hockey player there. The pelvic floor doesn't work on its own. And so when my brain asks my lower abdominals, my transversus abdominis, so these are the muscles that are right above the pubic bone, lower down. When my brain asks that muscle to work, there's a change in the diaphragm, and there's a change, my pelvic floor will also contract. When my brain asks my pelvic floor to contract, it contracts, and these come in. What happens for many people is when their brain asks the pelvic floor to contract, they sometimes go to the pelvic floor, and they go to the other team members, or when they go to the pelvic floor, they feel their lower abdominals, they're more aware of abdominals, and they tighten up on that. And if there was something in the pelvic floor, it dissipates. There has been, about 10 years ago, when this relationship was first identified, there was some work trying to teach the pelvic floor through lower abdominals, but the research now is very clear. You need to target the pelvic floor directly. It's not an effective way to make change for bladder control, accessing the pelvic floor through the lower abdominals. So it gets confusing for people when they tighten their pelvic floor, because the pelvic floor doesn't work on its own, and people are more aware of other team members. So when we're teaching pelvic floor, we want to teach this team member how to manage the puck, and the team follows along. This is the player in control. Now, sometimes that team member throws the puck to the other team. So if you throw the puck, you tighten your gluteals, your buttock muscles, your inner thigh muscles, your upper abdominals. you've just passed it to to a completely different team. It's not even part of the package that should be contracting with the pelvic floor. So we know that when you're tightening the pelvic floor, all parts work together and can be considered one. What's important is that we find the cue that works for each individual. And that's what we do in treatment. There is some research that shows that one cue is better than another when they do ultrasound imaging, but again, it's not for everyone. It's just for a certain proportion. And again, so when somebody is learning this, we need to find out the cue that works for that individual. So we're going to go through this again, and then we're going to do another poll and find out what the experience was in the group that's here today. And we're going to find that there might be some where more people find helpful and other ones that only a few people found helpful. So again, get in the position that's comfortable. I'm going to go through each of these cues one by one. I need to take a 10-second rest between each cue. That's just the way the muscle, I need to work it for it to work for people. So everyone in a comfortable position. I want you to put your awareness where your anal sphincter is and tighten that and keep it tight. Feel it. Just keep it there. Let it go. Okay, we're going to wait 10 seconds. Okay. Oops, sorry. I'm trying to find the chats. Okay. Tighten your perineum. That's the perineum is the area between the anus and the testicles. So tighten that. Let that go. Okay, now this time I want you to stop yourself from going pee. Stop going void, stop voiding. Let go of that. Okay, the next one I want people to do is lifting testicles, not with your hands, with your muscles. So pay attention to where your testicles are and lift your testicles. Let go. Now we're going to wait a bit again. Let go. Sorry, we were waiting. Okay, and now think of where the base of your penis is. Tighten that in towards your body. And let go. Okay, so now what I'm trying to do is I can't find, oh, I got it. All right, so we're back onto chat now. I want people to answer with a yes or a no, or Y or an N. How many people found tightening their anus to give them the best idea where to localize the contraction? So yes or no for anus. Okay. How many people felt perineum was the best? Okay. How many people found stopping going pee was the best? Okay. How many people found lifting testicles was the best? Okay. An interesting thing about lifting testicles, it's actually a really good cue for helping guys tighten their lower abdominals. The muscle around the testicles is not even part of the pelvic floor. It's a slip of muscle that goes down from the lower abdominals or for the internal obliques. But again, it doesn't matter as long as the cue works. The other thing, while I'm asking about these, again, it's only verbal and written instruction. I'm not seeing what anyone's doing. So some people might be thinking they're doing it correctly and they're not. but it's just getting feedback, what works, just different ideas. So what about tightening your penis towards your body? Pulling the base of the penis in. How many people found that the best one? Okay. The thing about that cue, I find that that is a cue that works, but when the person wants to maintain that contraction so they can integrate the contraction with an activity, it actually tends to be a very hard place for people to maintain the contraction from. And so not only tightening and relaxing is important, but maintaining. So sometimes that's, people might start there and then they realize they need to move somewhere else. What we find clinically is that tightening the anus or tightening at the perineum tend to be the best cues for men. One of the things we're going to be doing is looking at the research from one of the studies that we're pulling up, and in terms of outcomes, which contraction is working best, which cue, but we're finding perineum and anus. But again, it's individual. So these are some things that you can do from home. So if you're sitting, not wearing any clothing, looking at your penis, and you try and tighten, do you notice your penis tug in or pull in towards your body? Remember, again, this is individual. I have had some guys that have Olympic pelvic floors, their penis and their testicles barely even move. So again, these aren't 100%, but it's just different things that you can play around with and try at home. Anal stretch. What you can do is you can put your hands on your buttocks in the crack with your fingers very close to the anal sphincter, and just stretch your cheeks, pull on that sphincter just a little bit. Keep that pull on the sphincter there. Relax everything except for that pull, and then tighten and let go. Sometimes giving a pull helps people identify where in their body they need to localize from. The other thing you could do, wear a glove or a finger caught lubricant, and just put your finger at the opening of the anus or in up to the first knuckle. If you put your finger in, there's going to be a natural resistance. It might trigger contraction. Good, learn. That's part of your pelvic floor contracting. Wait till everything's relaxed. Don't move your body, don't move your finger. And then try to pinch your finger, or just at the opening, try to get a pinch. Not a light one, but a full one. Sometimes that physical cue can be helpful. The other thing you can do is you can put your hand like right down between the base of the testicles and the anus, right on the perineum. Excuse me. And you can just feel, when you tighten, you'll feel a rope pop up. You'll feel like if you press your fingers right here, just inside of the angle here, and you clench, you'll feel a muscle bulk out. You can feel a muscle bulk from below. Some guys hang a little bit off to the side. And so if you don't feel it at the center, move your fingers just a little bit to the right or the left to see if you can find it that way. Don't press really, really hard. You won't find it. Don't press so lightly, you're just on the skin. It's just gently, calmly into where the muscle would be. When you relax the muscle, if you do not feel that rope, so if you feel the rope contract, but you do not feel it relax, it is not because the muscle has increased tension and it stayed there. It's because the muscle slowly dissipated and you're not even aware of it. So it's a helpful one to learn just where to locate the contraction from. You want to make sure that you're not leading with your abdominals. Your lower abdominals are going to come along. It's part of the team. You want to make sure you're not tightening with your buttock muscles, and your breathing should be normal. We find that if people initiate a pelvic floor with a breath out or with a breath in, the minute they need to breathe, they lose that contraction because the breathing has been the driver. And if you need to, say, carry a box from point A to B or for a certain period of time, you need to breathe, and you need to be able to use all of your other muscles independently of what your pelvic floor is doing. So we really want to be able to target that muscle and use it effectively. So when we're using our pelvic floor, we want doing pelvic floor exercises, we want the pelvic floor to be the player with the puck. And you need skill in order to do that. And you need skill for contracting and relaxing. And once you know how to contract and relax, then we want people to learn how to maintain the contraction. Once you have that skill, the treatment branches off into two things. We want that muscle to be strong, and the exercise prescription depends on the person's skill. So it's not helpful for me to say tighten for 10 seconds et cetera, et cetera. If the person can only tighten and relax, they don't have the skill for contracting. So we develop a skill, and as skill develops, we increase the demand. The research shows that intense pelvic floor exercises are required to improve strength and endurance. Endurance can be really important, and I'm not going to go into the reasons why right now. I'm just sort of looking at my time. There are some men, they will pee in the morning and do a specific walk. In the evening or later in the day, they will pee and do that same walk, and they will leak in the evening, whereas they won't in the morning, for the exact same demand with the exact same bladder filling. And we think that that's because the muscle's fatiguing, and we really need to target endurance exercises. So we want to target strength and endurance. The person needs to be able to have the skill to do these in standing. That muscle has to lift against gravity. That's its function. And the prescription depends on what the person's skill is. You can be Olympic in skill and strength, and if you don't use it with activity, you're going to leak. Because remember, it's the automatic closure mechanism is not working. You have to use the intentional voluntary mechanism. So you want to contract and hold the contraction during whichever activity gives you leakage, and you only relax when that activity is over. Now, some people say, well, Marcy, for example, when I cough, I don't leak all the time. How do I know when I need to use it? And the thing is, you don't. So every single time you cough, you need to remember and have the skill to be able to tighten and maintain it during that activity and let it go when the activity is over. If you never leak when you cough, well, you don't have to worry about it on that one. Okay? So again, this is very individual. Some people leak with all of these. Some people leak with just one or two. So remember, there's a skill to this. If you don't do it correctly, it will not be helpful.
The audio's working now.
You have
Yeah,
to
the audio was working
remember,
fine. The only thing, when you got those windows,
I think somebody needs to mute.
talking.
If somebody's
You-
on,
you-
muting their mic.
Like he's talking, and then he changed someone talking. It
So-
changed, right?
Yeah.
Mine.
Please
If you
turn off
don't,
your mics.
There's no, I don't think your camera's on.
it's on. So if you don't remember and tell your muscle to
you-
contract at the appropriate time, your pelvic floor exercises will not be helpful. It's an intentional muscle. It's an intentional voluntary closure bladder control mechanism. You have to intentionally contract your pelvic floor with activities associated with leakage. In order to do that, you need the skill and the strength and the endurance for whatever is needed in that moment. Now, I can't find my chat again, but what I often get is, does this mean when I walk, I have to hold my muscle tight for 15 minutes, 30 minutes, an hour? No, I don't think that that's a realistic thing to do. You're not going to enjoy you're not going to enjoy your walk. You're going to lose the beauty of your walk, and you're not going to have any social connection with whoever you're walking with. It's not possible to focus and keep that muscle intentionally contracted for an ongoing activity. I do want people to know how to use it, the muscle, for ongoing activity. And over time, the intention can translate to habit. But that's a whole other research question and issue that I'm happy to discuss. Contact me, but we're not going to do that right now. It's got to do with neuroplasticity and motor learning, but we're going to leave that there. So this leads into the next thing. Somebody comes in to see me for treatment. They want to get dry, and I get that. And I'm going to do, as well as every single person in their healthcare team, we'll do every possible thing we can to help that person get dry, 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 dry. But until that happens, or in case it doesn't, we don't want you missing any moments. I really want people to try to embrace the concept of, I'm going to do everything I can to get dry. And until then, I really want to live my life fully and do everything I want to do and enjoy doing it and feel confident about my bladder management strategies. So I'm going to take a little bit of time talking about absorbent products, clamps, urethral inserts, and condom drainage, because those are all other ways of managing, even if you are having some incontinence. So there are different absorbent products. There are some disposable ones. There's disposable ones. There are also some washable ones. There are pads. There are briefs. I really encourage people to use male products. Men leak from a different part of the anatomy. Female products are geared to pick up from below. Male products lower down but in front. And also a menstrual pad and a continence product the substance is different, and incontinence products are meant to wick moisture away from the body, so they're better for skin. Some people, if you're wearing a brief or a pull-up or an adult brief, it can be really difficult if you're going out in public. So you're out at a restaurant or the mall and you've got to go into this little stall and you've got to change that brief. You have to take your shoes off, your pants off, the brief off, figure out where to discard it, what to do with it. You've had to carry in another one. You got to put that on, put your pants on, put the shoes back on. It's a lot, fussy, small space. So what we recommend is if you're wearing a brief and you want to go out, or even if you're just for management at home, sometimes it's helpful just to put a pad inside the brief and change the pad. If you do put a pad inside a brief, make sure that the brief that you're wearing is form-fitting. You won't need to use the adhesive on the pad. If you use the adhesive on the pad against the brief, when you pull the pad off, it breaks apart the brief and it's not as effective and it just doesn't work as well. So if it's form-fitting and snug enough, that pad will stay in place without needing the adhesive. These are some sites, I think they're still active. You can request some samples. There are other ones if you Google. These are just ones that I happen to have handy. So those are absorbent products. There are also washable products that you can find. If anybody knows of a washable product that's form-fitting and works really well, please send me that information because I would love to share that with other people. So another device or another way of managing incontinence are penile clamps. These are external devices worn on the shaft of the penis. They just compress the urethra and they stop urine flow. Heads up, which I learned very early doing this work, I think for my first 1 or 2 clients using a clamp. If you're using a clamp, when you go to take that clamp off, make sure you are sitting on the toilet with the opening, the meatus, the opening of the urethra at the tip of the penis pointing directly into the toilet bowl. Because the minute you undo that clamp, whoosh, there's going to be a flow of urine that it is not possible to hold back, even if you're perfect with your pelvic floor. So these are some things to know about clamp use. You have to be cognitively intact, have to have normal genital skin sensation. If it's pinching or too tight, you want your body to be able to signal that to you. If your skin has broken down or you have any other skin condition, you don't want to be wearing a clamp. You have to have good intact skin on the penis. You have to be aware of bladder filling. Sometimes if people are leaking a lot, the bladder never fills to the point of awareness. So if your bladder gives you a message when it fills that your bladder needs to empty, then it's okay. If the person for whatever reason doesn't have awareness or the ability to not have that awareness, you shouldn't be using a clamp. And you have to have the finger dexterity to be able to open and close a device. There is research, and we hear often from client report that it definitely improves quality of life. If you're going to be wearing a clamp, I recommend if you're in that first year post-op to use it judiciously, not all day. Within that first year, even up to the second or third year, but definitely within that first year, there can be some automatic return. And if you have a clamp on all the time, you're not going to be aware of the change in your continence situation. And you're also not going to have opportunity to learn how and practice integrating your pelvic floor contraction into activities and movement. So I would recommend that it's absolutely, you want to go and dance, you want to go out for drinks, you want to go on that hike, you're going away for a few days, use it intentionally with choice, but at the same time, try to be aware of what's happening with your continence and learning how to use your pelvic floor. Remember to limit wearing time as per product instruction. Do not wear a clamp at night in bed, and don't wear if you have an implanted penile prosthesis. So this is just some information. I found really good feedback on the Uriclac and the Weisner. Other people have used the other clamps that I'm going to show you as well with success. So again, whatever's available, whatever you can access, which ones are more comfortable. So those are 2 of them. There's also the Pacey cuff and the dribble stop and the Cunningham. The Cunningham is the only one, it's been around for as long as I've been working in this area. It's the only one I know of that's available in pharmacies. All of the other ones are available online. The next management, so we've got absorbent products, we have clamps. There's also urethral inserts. So a urethral insert is a device that's inserted into the urethra. It temporarily blocks involuntary leakage. The person removes it right before they pee. They put it back, clean it, put it back after they finished voiding. It must be fit by a healthcare professional. I do like to have full disclosure. I do consult with the next product I'm going to show you is a urethral insert. I do consult for Contino, and I teach other health professionals how to use this device. So I just want people to know that, but I'm presenting it as one of the many options that are available to people. So this is a picture and the contact information for Contino. So this is the person without anything, and this is just how the Contino fits in, and it just stops urine flow. You want to pee, you take it out. And you want to, you finish voiding, you put it back in. This is the Contino. There's an insert. The Contino goes inside the insert, and this is inserted into the urethra. There are these depth markers, and the person inserts it in between the depth marks, anywhere in between. Once it's inserted to that point, you stop insertion. You just flip this out of the inserter, and you withdraw the inserter, and that's it. And again, some people use this at night. And so this would be a person that's having significant incontinence. They use a condom drainage. Some people use it day and night, some people just at night. I very rarely have worked with men post-prostatectomy or down the road long-term radiation that are using this, but it is another option, and I have recommended this to some people. There's a condom. It's not a typical condom. It's a specific condom that's meant for urine collection. It has it's manufactured with this piece that attaches onto a tubing, a catheter that goes into a leg bag. The leg bag can be attached to the thigh or to the calf. As that bag gets full, the person just goes to the toilet or the urinal. They loosen these straps. They move this over the urinal or the toilet. They open the valve, drain the bag, close the valve, put it back, put their clothes on, and go on about their day. There is research that shows that pelvic floor physiotherapy is beneficial for decreasing incontinence and improving quality of life. There is some evidence for pre-op physiotherapy, you get your outcome better, or you get better outcomes. And there is some research that shows that biofeedback is helpful. The biofeedback is used in all of the prostate cancer supportive care program in clinic appointments. But I want people to remember biofeedback is a tool. It is not the treatment. It's a helpful educational tool for the client. And in some situations, it can be very helpful for the physiotherapist, because the person could be standing, we can't see their pelvic floor, but the biofeedback can be reaching it. But again, we're finding with telehealth, based on a specific way of treating, we're finding really good results. We're not using the biofeedback, so it's been a big aha moment for me, but it is a really helpful tool. But remember, it is not the treatment in and of itself. It's a tool. So there I am. I think I pretty much got it in. Where can I find, I keep losing, there. If anybody has any questions, please let me know. There we go. I found the chat again. So shoot your questions to me on chat, and I'm happy to answer.
Hey, Mark, it's Len Gross here. Mark, I want to clear my chat stuff. How do I do that?
Okay, so I have a question about what is biofeedback in this context. Sorry, it's a really good question. So there's different ways of using biofeedback. In terms of pelvic floor for men, you can have a probe that's inserted into the anus, or surface electrodes just put on the outside. So again, we just move the buttocks gently and put a little sticky on either side. What the electrodes do is, have you ever had your heart monitored? So you get electrodes on your chest. It does not give you any electricity, picks up the electrical output of the heart muscle, and it puts the contract and relax on a screen. So you can see when the muscle is contracting and relaxing. That's an automatic muscle. The pelvic floor is a voluntary, intentional muscle. So the biofeedback picks up the contract, the hold, the relax, but you can control the graph because it's a muscle. So when you contract, it goes up. When you relax, it goes down. If you're maintaining, you can see that you're maintaining. If you think you're maintaining and you're not, the graph starts dropping. So it's really, really helpful because a lot of people, holding that contraction is the hardest thing. A lot of people think they're maintaining the contraction, they're not. So it can be really, really helpful. When I first started this area, I used the inside the rectum probes. I haven't used that for decades because you get equal information from the outside right by the anus. Equal information is less expensive, it's less invasive, and clinically, it's so awesome because the person can stand up and and be in a standing position while the biofeedback's on. If you've got the rectal probe in, you can't really stand with that probe in. It just makes a mess. You got to either hold it or tighten, and the holding gives interference. Some people use the biofeedback, the external surface, when the person's moving. I don't feel that that's effective use. Any biofeedback that I have seen, the ones for assessment or treatment, there's too much interference from surrounding muscles, even if the system cancels them, for me to really believe or have confidence in the biofeedback read, in my experience. And also, by the time that the person's moving around, I want them to know what that muscle feels like inside their own body, so they can be their own biofeedback. They know what it feels like as they're integrating into function. So I hope that answered the biofeedback question. If it didn't, ask me again.
Other questions?
What is the typical incontinence recovery time after green light laser therapy for BPH? I'm not going to answer that in a time frame. Again, it's really individual, and it depends. Yeah, it just depends on the end result. If there was any changes to the internal sphincter. It also, somebody's had BPH, they get changes in their bladder. They might have developed other bladder habits. So it's a big question. And that one it's really individual. I would say anytime you have surgery, there's tissue healing time. And that, 6 to 12 weeks for general healing time, but it could be even a bit longer. And I'm not able to answer that one on a typical. It's really individual.
Marcy, I have a question that maybe
help.
The question I had is the supportive care program on a Zoom system of presentation?
Yeah, absolutely. So some of the sites I think Victoria and maybe Prince George now, you can go in clinic, but anywhere, Victoria, Prince George, anywhere you are in the province or the Yukon, you have the option of in clinic. If they're doing in clinic, you have the option, and whether they're doing in clinic or not, everyone currently and going forward, whether COVID is in our lives or not, there will be the option for telehealth or virtual health. And like what I said is earlier, we're finding amazing outcomes, and we're actually putting it together and publishing. So it's going to be really interesting. We don't actually have all the stats together, but what we're finding clinically is fantastic. So again, with the type of treatment that we're doing in the program, which is really teaching people how to be aware of where and what in the body they should be feeling when they're doing a contraction very specific to the pelvic floor.
I think that's very good because it's an opportunity to have conversations with the person who's delivering. So it's feedback you're getting immediately.
Yeah. And some people say, well, I really want to be in clinic, and I get that. But what we're finding is just awesome results. And even if you can't be in clinic, and what's the loss? It doesn't cost you.
No.
And you can access this from anywhere in the province or the Yukon. It's like, oh my gosh, this is like a silver lining to COVID. It's really pushed not only our program, but I think a lot of healthcare forward in access to outlying areas. Yeah.
It's one of the great benefits of the COVID-19.
Yeah. Yeah.
While COVID-19 is not a benefit, but
no, but it's a silver lining. It's a silver lining.
Results.
Yeah. So how frequently should we practice pelvic floor exercises each day, and for how long each time? So if I have a headache, I'm going to take 200 milligrams of Advil. If I take 50 milligrams now, 10 later, 50 later, and 50 later, it's not going to help. And if I keep taking 100 milligrams right now, or every 15 minutes or 10 times a day, it's silly. It's not helpful. It's maybe even harmful. Although I don't think too many pelvic floor exercises, well, there's a whole debate there. Anyways, the point is, it depends on what your individual need is in terms of where you're at with your skill. If you want to play Mozart on the piano, you have to learn how to get there. So first of all, it depends, does the person know how to contract and relax? Can they hold the contraction for 3 seconds? Can they hold it for 10? What I like people to do is 80 to 90% maximum contraction, 10 seconds on, 10 seconds off in standing, 3 sets of 10 in a row. And then the person says, and then once a day or every other day. People say, well, I'm working my biceps. I don't do that every day. Yeah, but biceps are a different type of muscle fiber, pelvic floor muscle. And then I also give an endurance exercise as well on top of that, so that I'm hitting strength and endurance, and we teach how to integrate with function with activity that causes leakage. So I can't tell each person how many or how long they should do it. It depends on where their skill, strength, and endurance is. And that's what we individualize in the individual sessions, whether it's telehealth or in person. I've tried to get an evidence base behind, do I get people to do this every day? When you're learning skill, yeah, every day, you're going to practice every day. Once a person's got skill and they're into strength and endurance, do I do it every day? Do I get them to do it every other day? It's a whole debate, because the muscle fibers for the pelvic floor are different than for biceps and glutes. They're a more slow twitch fiber. I've not been able to get a definitive answer. I've not found negative impact on the clients I've worked with that are doing a full dose every day. I've only found benefit. I am so keen on getting, I've approached a couple different universities and other people out there in the research world. If anybody is listening to this and has some evidence base for the pelvic floor specific, I'm happy to hear it and work with that. I've looked at the American Society of Sports Medicine or American Academy of Sports Medicine, and they've been the best, but again, I can't find reference to an evidence base behind it that fits for pelvic floor specifically. So that I can't answer that one again specifically. I hope that was a good answer.
I don't see any other questions people have. No other answer? Oh, I don't hear any other answers. Are you getting any other questions, Diane?
Marcy? No, I'm not getting any questions here. So maybe that's it. You've got my contact information. I'm happy to answer questions individually. After the talk I did on Tuesday, I had a few questions, and I'm really happy to see all of you at the Prostate Cancer Supportive Care Program.
Thank you, Marcy. Thank you very much for taking time to be with us today.
Yeah, you're welcome.
I'm sorry I'm getting an interruption here.
Yeah, I just want to also say thank you for inviting me. This area of work has been rewarding and wonderful. And I just think it's an amazing opportunity to be able to share this information. So thank you for inviting me. I love my work and I love sharing the information, and I hope it's helpful to you and to others.
There's been some benefits for me for sure. And I've been at this for a little while.
So.
And I do have one of those conditions that you described, a stress incontinence issue. So
yeah.
And I've had it for more than 20 years, so I'm fortunate to be able to deal with it. So thank you again for your comments and your help that you provided. And we do have your address in the event that anybody has a question that they wasn't dealt with today. They have an opportunity to use the website to get back to Marcy, who will be prepared to answer your questions. So again, thank you on behalf of all the guys. It's been a pleasure. And you can show your appreciation by showing your reaction on the bottom of your screen. You can have a hands up or clap or whatever you like to there. Good. Some people have actually found that signal.